So welcome to the second in our series of Zoominars on healthcare topics for general practice. My name's Andy Powell. I'm a partner in Mazars healthcare team, and my fellow presenter is...
So my name's Rob Day and I'm Principal Associate and Solicitor at Mills and Reeve.
So today's updates on primary care networks and the legal and accounting side of things. So we're going to start with the first slide on legal issues.
Yeah, thanks, Andy. So very high level, because obviously we're trying to keep these bite size. I thought what I'll do is look through some of the general considerations or points to draw out in relation to the new network contract DES. So some of the core points really to bring out. So as was the case with last year's DES, and as will be the case with all subsequent years network contract DESs, the term will be from the 1st of April till the 31st of March. Interestingly, and probably an understandable addition to the DES is this concept of auto enrollment. So in order to cut down on the administration of, and probably the disruption as well, of members of networks leaving partway through any contracting year, participating practices are automatically deemed to accept variations and also subsequent iterations of the network contract DES unless they specifically opt out. So in terms of opt out, what that means is you will have a limited period of time, in fact 1 month from issuing by NHS England and NHS improvements of the revised variation or revised specification to identify that you don't want to participate. So that's an important point to note, otherwise you will automatically be deemed to accept and continue as the variations come live. In terms of prerequisites, they remain exactly the same as they were from last year. So patient list size ideally is between 30 to 50,000, albeit as we have seen over the last year, there is quite a degree of flex there, and commissioners can agree smaller and indeed larger PCNs in terms of their patient coverage and geographical area. All members of the primary care network need to have signed up to the network agreement. So in essence, that's a network agreement which covers the mandatory terms which are issued by NHS England and agreed with BMA, and also any varied schedules which have been agreed between the members themselves. You must identify your nominated payee, your appointed clinical director, and have in place appropriate data sharing arrangements as between the members. Now, in terms of the next core consideration, it's subject to a minimum term. So subject to certain exceptions there, and I've mentioned two, which is obviously the loss by a practice of their primary medical service contract or an approved expulsion, which I'll come on to in a bit. The current DES specification must be delivered until the 31st of March 2021. So even if there's a decision that you no longer want to be involved in the practice, or you want to remove a practice, technically speaking, unless you go through set processes, you will have to continue to deliver it until end of March next year. So moving on to the next slide, please. Other considerations that I wanted to draw out, I was going to say that sort of interest me, but I suppose interest with a small eye. There's provisions there covering unwanted practices. So there's now a process, and I suspect it's because there's been various situations where sort of practices have been left in a situation where they're not being accepted by other groups or other practices within their locality. But there's now a process where commissioners can assign a practice to a PCN. So this goes through a process whereby effectively the commissioner will work with the LMC in order to reach an agreement between the parties. But ultimately, if they decide they wish to do so, they will notify the practices involved by the 30th of June as to the fact that they require the relevant practice to be placed within a specific PCN. That then triggers a period of time of 30 days where the relevant parties to that network have to take such steps to realise that placement. Next point, expulsion and relationship breakdown. As said, sort of in line with that minimum term requirement, any mid-term expulsions or breakdowns in relationship will need the commissioner involvement, and ultimately will need their approval. So it's not just simply a case that your network agreement provides or may provide for the fact that you can expel a party for any specified reason, or indeed for no reason at all. It's just a breakdown of relationship. It's not just as simple as that. You will need to involve your commissioner, and they will go through a process to see whether a resolution can be found before making a decision one way or another. As is the case with any sort of contract, core contracts, or your GMS, PMS, when you're dealing with mergers or splits of practices and the necessity to involve commissioners, your CCGs will now consider the impact that that merger split will have on the relevant primary care networks as well. So you can expect that will form part of any application process that you make to merge or split a practice. Final point on this slide is really a point that we know that there's some confusion over, and a bit of concern is the process for contract management. So if there are issues or perceived to be issues under the PCN Desk, what action can and will your commissioner take? So the DES is very clear on the fact that the desired approach is one of creating action plans and looking to resolve the issues in accordance with those plans. But it does go on to stipulate that as a last resort, the contract sanctions which are available under your GMS, PMS and APMS are there and are possible to be implemented. But interestingly, it stipulates clearly that they can be used to effectively terminate their involvement in the PCN Desk. So what it doesn't do is it doesn't extend to say your breach and the termination of your involvement in the PCN will automatically trigger the end or a contract sanction under your main and primary NHS contract. So next slide. Yeah, so two final points on the general considerations is additionality. That's here to stay. So when we talk about additionality, we're referring to network staff. So 2 points to remember there, one of which is a new one. The first, which is the same as last year, in essence, to access the additional role reimbursement scheme, the staff must be additional to the practice CCG baselines which existed as of the 31st of March 2019, and those baselines will continue to apply until the end of the 5-year expected term of the PCN Desk, so 2024. And those baselines are in respect to the 6 reimbursable roles which are listed on the slides there. Importantly, in relation to that additionality, and it's one thing which has obviously caused a few headaches for PCNs over the last year, is what happens if there's a vacancy in your baseline, if as a result of somebody leaving or you removing somebody from your practices which fall within the baseline, what happens to your funding? Well, it's now been clarified within the updated DES that the funding will reduce, but that will only take place after 3 months if the vacancy persists. In relation to that point, what I'll be saying there is it's important for you to consider how you will deal with that as between practices within your network. So will that be a liability on the practice where the vacancy has arisen from? Will it be shared by everyone? It's just something to consider and to document clearly. And the last point on the general considerations is service delivery and how you need to actually deliver the services under the PCN Desk. Now, this remains, as it was before, a complete decision for the PCNs to decide and the practices involved. So the obvious ones we're still seeing are flat contracting, method of delivery, lead practice, and also subcontracting. And interestingly, in relation to subcontracting, what we're seeing is 2 types of subcontracting taking place. One is to a provider arm which has been set up specifically by the practices involved in the network to effectively help them deliver services, and or subcontracting to a third party. So moving on to the next slide. So the obvious thing is, well, what are you required to do under the PCN Des? So I've done a slide there just identifying what the services are under this year's PCN Des, and also the key dates to bear in mind in terms of when those services are to commence. So you've got extended hours access, which effectively is just to continue as it was from last year. You've got structured medication reviews, which start from the 1st of October 2020. You've got enhanced health and care homes, and there's a few elements to that, and the timescales are split. So by the 31st of July, there's a necessity, for instance, to agree which care homes are going to be aligned to your specific PCN. So the so-called PCNs aligned care homes. And ultimately what you'll need to do is prepare yourself for the start of the service delivery there, which includes carrying out weekly rounds to those care homes as of the 1st of October 2020. You then have early cancer diagnosis as a service, which is to start from the 1st of October, and then a social prescribing service, which there's no date specified within the DES, so the inference there is that it starts from the 1st of April. So moving on.
Okay, thanks, Rob. I'm just going to have a look at a few financial aspects. These have been covered in some detail elsewhere previously, but in terms of what's changed. So in terms of the PCN funding for 2021, there has been a significant change in that originally NHS England's intention was for PCN additional roles to be 70% funded, with 30% then to come from practices. And unfortunately that didn't result in much investment at PCN level, and many PCNs didn't actually employ anybody in the first year because they were concerned about this aspect. That's now changed to 100% of funding of the approved additional roles going forward. And whilst there is quite considerable concern about some of the contractual requirements of PCNs and much debate over them, I think what we have to focus on is this is going to be a significant source of funding going ahead for practices through the PCN route. And if we just have a look at the funding side of things, for an average primary care network in 1920, you're probably looking at a reimbursement of probably 75,000. This year it's 244,000, and moving up to 2023-24, that's going to 1.1 million. So it's a substantial investment in staffing in primary care. And the risk is that if you're not involved in PCNs, you won't be able to access that funding. The second big change is that NHS England have given a commitment post 2024 that funding will continue, maybe not through the PCN route, but through the core GMS contract. And whilst that's not legislation, there is a commitment that this will continue, and there was some concern originally that people would have to be made redundant after 5 years. So hopefully that concern's gone away. The other change in 2021 going forward, and this was in the original PCN spec in 1920, is that the PCN funding is now linked to the weighted list size of the PCN practices, whereas in the first year it was just based on actual list sizes. So areas that have a high weighting in terms of the Carhill formula will get more funding. So we just have a look at the next slide.
Just to say, Andy, when you said 1920, do you mean 2020?
No, I meant 1920.
1920?
As in 2019-20.
Oh, right, okay. With you. You can edit that out.
Okay. So the other aspect in terms of investment that's coming in through the PCN route is through the Investment and Impact Fund. And this also is quite significant. So across the country as a whole, that's going to rise from 40.5 million in 2021 to 300 million in 2023-24. So a substantial rise in funding. The Investment Impact Fund is a reward-based system. So it's a reward to PCNs for delivering the objectives. Start again. So it is a reward-based system, and it's a reward at PCN level for delivering the objectives of the long-term plan through the NHS. So it does need the PCNs to work closely together to the objectives, but again, a substantial area of funding and not to be dismissed really. So we just have a look at the next slide. Just some key tax issues, and these again have been discussed at length elsewhere, but just to quickly go over these. And the first one is if a PCN makes a surplus in terms of its investment, and that's it mainly in relation to the £1.50 monies that per patient that are being given to PCNs for managing them. If there's a surplus, that surplus is taxable on the individual practices. So you just have to bear that in mind in terms of your accounts. It's a DES, so there isn't a legal entity actually created through the creation of a PCN unless you go down the corporate route. So it's no different from any other DES income that practices receive, and they need to be accounted for within the practice accounts of those constituent practices. So there does need to be some accounting information that flows between the PCN and the practices to deal with that. The PAYE status of the clinical director has been much debated, and HMRC didn't help matters at the BMA conference in February this year by raising this as a substantial issue. Discussions are still ongoing between the accounting organisations, HMRC and the BMA on that, so hopefully we'll get a resolution soon of that. And the final point is that VAT is not to be dismissed. VAT is often not considered because healthcare is exempt from VAT, but PCNs do throw up a bit of an anomaly in that potentially you've got a supply of staff between practices rather than a supply of health services, a supply of staff being VATable, a supply of health services being not VATable. And one of the mitigating ways around this is to look at cost sharing exemptions, but they need specific terms. So one of the areas next to consider is that a lot of practices are looking, or a lot of PCNs are looking at whether using a corporate vehicle is relevant for the PCN. So we just have a look at the next slide. So as I said, some PCNs are looking at incorporating their PCN as setting up as a separate legal entity through a limited company. The benefits of this is it's a clear separate entity, so the PCN exists as its own right. If there's any surplus that exists within that PCN, it's taxed at a rate of 19%, the corporate tax rate, rather than a higher rate tax of 40%. If it goes through the partnership route, so it actually leaves more money within the PCN to invest. That assumes there is a surplus. If practices, PCNs and practices spend all their management a resource, then there will be no surplus. The tax really isn't an issue. The corporate route throws up the opportunity, if set up properly, to use cost sharing exemptions under VAT. And basically cost sharing exemptions can be applied in certain circumstances, and the rules are that where there's 2 or more organisations with exempt non-business activities, so provision of healthcare is exempt, if they join together and on a cooperative basis, they can form a cost-sharing group. So that sort of, everything a PCN points to is a cost-sharing group, but the key issue with cost-sharing groups is a cost-sharing group must be a separate independent entity. So you do have to set up a separate vehicle for that to apply. So simply just coming together and having a separate bank account doesn't form a cost-sharing group. If you formed a limited company to deal with the PCN, it does potentially form a cost-sharing group. So that's quite an important thing. NHS pension side of things, at the moment we have a temporary access to the NHS pension scheme until 2021 for any corporate entity formed for the purposes of providing PCN support. So staff can join the pension scheme, and as far as we're aware, 2021, whilst it doesn't seem particularly far away, we understand that discussions are underway to extend that beyond that, which would be a sensible solution. a corporate entity also allows for future investment and development of services. You know, if PCNs are looking to develop services beyond the core PCN, you know, sharing of staff, and looking maybe at other cross-practice roles like management, if we're looking at actually becoming a provider of other services, then the corporate model does suit it quite well to that. So, you know, you do have to look at the future. But we just have a look at the cons now. If we look at the next slide. So the cons are it's setting up a limited company is another tier of administration. And if you have seen our video on incorporation of practices, we cover that in some detail, but it does need to be considered. You do need to deal with the legal complexities. So it's not just a case of buying an off-the-shelf company and away you go. There are various issues that need to be considered, which we'll deal with in further slides in this presentation. If the PCN ceases to exist, or if that's through internal decisions, so practices deciding to opt out of primary care networks, or changes in national policy, which mean that PCNs are no longer the vehicle of use, then you would need to wind up the business. Whereas if you're an informal network, then it's slightly easier to wind that up. Practices coming and going from within the PCN, be it through merger, acquisition, or just deciding to leave the PCN in a corporate environment will be slightly harder to deal with. Not that you can't overcome it, but it is a con. So I think the core issue around incorporation very much depends on your view of the PCN as a long-term organization. If you see your PCN as being a long-term active organization that is going to invest further through the PCN route in its practices and looking at developing services, and you can see the services that you are going to develop, then incorporation is probably more for you. If you're operating in a more informal model at the moment and haven't really employed many staff, and whilst you might see yourself employing staff, you don't see yourself providing more services beyond the additional roles, then it may not be for you. So you do have to consider the long-term nature of the organization. One of the alternatives would be to use federations as perhaps the model to provide some of these services, employ some of these staff, because a federation could tick that cost-sharing exemption solution. So it may be that you use federations, and many areas are using federations to just provide that back office function for PCNs. So we're just going to have a look in the next two slides quickly at some of the contracting and some of the other considerations to look at. And I'm going to pass back to Rob on this, who's going to deal with subcontracting.
Thanks, Andy. Yeah, so really leaving you with some sort of takeaway. I mean, if you are looking to use a third party, then that may be your GP federation, or it may actually be the provider arm that Andy mentioned you may create yourselves to actually deliver the PCN and there's service requirements. You know, be careful, because that is an arrangement with separate corporate vehicles, separate parties, and you are still primarily responsible under the PCN Desk to deliver the service. So in all other circumstances, you would be looking to document exactly what it is that's being provided and how it's going to be provided. And it's no different here. So first thing I would say, if you are looking to involve a third party, whether that's some third party you've created or one which is in existence and it's an arm's length third party, remember that the provisions in your primary medical service contract regarding subcontracting will apply. So in essence, it needs to be reasonable in the circumstances, and you must be conscious of the fact that they must be suitable and qualified to actually provide the services. Also, your commissioner can ask for information on the subcontracting arrangements. But in terms of the actual subcontracting terms, think about whether you need to cover off all, if not some of these points here. So term and termination, costs, services to be provided, obligations on the various parties, you know, information sharing, insurance liabilities, exit arrangements. So when a party say the arrangement comes to a complete end, what are the exit arrangements in terms of dealing with staff and dealing with the smooth wind up of those arrangements with one another. And remember, there needs to be a prohibition on further subcontracting, as there is a prohibition under your GMS PMS contracts, which stipulate that a subcontractor cannot subcontract further. So just bear that in mind. If you are looking to subcontract, maybe cross-refer back to this slide and just think, have I covered these elements off? So moving to the last slide. And really, it's sort of going back on something which Andy mentioned, and this is this establishment by the actual practices involved in the PCN in creating its own provider arm to help it support on the PCN Desk. So these are points which have been covered in more detail in our previous session on incorporation of practices. The types of vehicle available will be company limited by shares, guarantee or limited liability partnerships. And there are pros and cons. It's not all pros. Yes, the pros are limited liability. It's a separate legal entity for contracting purposes, so it can enter into contracts with staff, third parties, etc., as opposed to it having to be entered into by individual practices or their partners. And as Andy said, it could be set up as a cost sharing group. But there are cons. Aside from the accounting cons, the legal cons are there's clear setup and ongoing costs when it comes to creating the vehicle and also its administration. So when parties join, when they leave, annual accounts, etc. And also there's a necessity for a board and a board of directors. But if you were minded to go down that route and it does make sense for you in the circumstances, then I've given an indication there of the high level steps. So you would be looking to incorporate, so in essence, create the vehicle, drawing up the articles and shareholders agreement, effectively governing the terms that are applicable to the company and the terms upon which the shareholders will effectively hold shares in the company. You'll be looking to obviously make sure that it's got access to NHS pensions. As Andy mentioned, there's a direction which will last until the end of next year, which we expect to be extended. But that needs to be borne in mind if you're going to employ staff through this vehicle. If it's providing regulated activities itself, it will need to be separately registered with the CQC. You're likely to need to update your network agreement to incorporate the provider arm. And unless it's going to be covered in the network agreement itself, you're going to need to look into the sort of contracting arrangements between the practices within the network and the provider arm itself, so it is clear who is to do what and what the obligations on the parties are. So that is it from Andy and myself in relation to primary care networks. If we go on to the very final slide. Yeah, so thank you for joining us. If there are any questions in relation to anything that's been raised in this session, please do contact either myself or Andy. Our contact details are there. And we hope you join us in the next in the series, which will be released next week. Thank you.
Okay.